So good morning, everyone. Welcome to this Untangling Amyloidosis session. My topic today is going to be high-dose chemotherapy and autologous stem cell transplantation in AL amyloidosis, its role in the era of emerging new therapies. These are my disclosures. I will start by a case presentation of a 48-year-old woman with AL amyloidosis diagnosed by renal biopsy when presented with leg swelling and protein in the urine. Her renal parameters included low serum albumin, normal serum creatinine, 24-hour urine protein excretion of 7 grams per day, and estimated GFR of 75 ml per minute per meter square. This placed her into renal stage 2 disease with eGFR of greater than 50 and 24-hour urine protein excretion of greater than 5 grams per day. Her cardiac parameters included elevated NT-proBNP, elevated BNP, normal troponin I, normal left ventricular ejection fraction, and a New York Heart Association class 1. This placed her into Mayo stage 2 disease and Boston University stage 2 disease as well, with elevated NT-proBNP, BNP, and normal troponin I. Markers of plasma cell dyscrasia were elevated free lambda light chain levels, normal serum free kappa light chain levels, and an abnormally low ratio. Bone marrow biopsy showed 5% lambda-typic clonal plasma cells with normal cytogenetics and FISH analysis. Immunofixation electrophoresis of urine showed free lambda light chain monoclonal protein. What is the best option for treatment for this 48-year-old lady? And the options are oral melphalan dexamethasone, high-dose melphalan and stem cell transplantation, cyclophosphamide bortezomib dexamethasone, Cybor-D, bortezomib and dexamethasone, or RVD, lenalidomide bortezomib dexamethasone. Please vote on your phones, on your... I think we are done. And I'm glad that this is what came up. So Cybor-D is the winner. Majority, 54% of the audience voted for cyclophosphamide, bortezomib, and dexamethasone as the treatment of choice for this 48-year-old lady with AL amyloidosis with renal stage 2 and cardiac biomarker stage 2 disease. In the next 20 minutes, I'm going to try to convince you that high-dose melphalan and stem cell transplant probably is a better choice for this woman and is better choice for some selected patients with AL amyloidosis. So this would have been my answer. Again, my bias is, or my disclosure here is that I'm a transplant physician. So high-dose melphalan and stem cell transplantation was developed for the treatment of AL amyloidosis in the early 1990s. The development of this treatment approach was prompted by promising results of similar regimens in the treatment of multiple myeloma. Objectives of the initial clinical trials were to determine tolerability of this treatment approach in patients with multi-system organ involvement, to determine efficacy of this treatment in inducing complete hematologic response, and finally, to determine whether complete hematologic response leads to reversal of amyloid-related disease and improved survival. Prior to 1990s, conventional treatment consisted of oral melphalan and prednisone and 2 randomized pivotal clinical trials, one performed at the Boston University and other one performed at the Mayo Clinic, showed that the oral melphalan prednisone improved survival of patients with AL amyloidosis to 12 to 18 months. However, hematologic complete responses, long-term survivals, and organ responses were rare with this form of treatment. Long-term outcome of first 80 patients following stem cell transplantation was published by our group in the early 2000s, showing that the median overall survival was greater than 10 years for those who achieve a complete hematologic response compared to 4.1 years for those who did not achieve a complete hematologic response following stem cell transplant. Newer anti-plasma cell therapies are questioning the role of stem cell transplantation in AL amyloidosis. Novel agents have been incorporated into different phases of stem cell transplantation for AL amyloidosis, either as induction therapy or as conditioning regimen along with high-dose melphalan, or after stem cell transplantation as adjuvant therapy or consolidation therapy. A phase 2 prospective clinical trial of 35 patients with new diagnosis of AL amyloidosis received 2 cycles of induction therapy with bortezomib dexamethasone, followed by bortezomib high-dose melphalan conditioning and stem cell transplantation at Boston University Amyloidosis Center. In this trial, there were high rates of hematologic responses with 63% complete hematologic response and 37% very good partial hematologic response. Moreover, there was no negative impact of bortezomib induction on stem cell collection. However, 5 of 35 patients, that's 14%, who were eligible for stem cell transplant at the time of enrollment did not proceed to stem cell transplant due to clinical deterioration during induction therapy. Long-term follow-up analysis of this trial was recently published with a median follow-up of 77 months, showing median overall survival and progression-free survival have not been reached. Furthermore, hematologic relapse occurred in a low percentage of patients at 15% at a median of 42 months, and organ progression occurred in 4% at a median of 37 months. Deep organ responses were also evident on this trial, with renal and cardiac responses occurring in 65% and 88% respectively at 5 years post-stem cell transplantation. A randomized prospective controlled trial of induction therapy with bortezomib and dexamethasone followed by stem cell transplantation versus stem cell transplantation alone in the treatment of AL amyloidosis with renal involvement was published by the Chinese group, again favoring induction therapy prior to stem cell transplantation with respect to hematologic complete response at 1 year and overall survival at 2 years. Recent publication from the HOVON 104 clinical trial, which was a phase 2 trial of 50 patients with new diagnosis of AL amyloidosis, received 4 cycles of bortezomib dexamethasone induction followed by stem cell transplantation, showing a hematologic response rate after stem cell transplant of 46% complete hematologic response and 26% very good partial response. On an intention to treat analysis, hematologic complete response was 32%. The conclusion of this trial was this was a futile trial because of pre-planned statistical design which did not meet the hematologic complete response guidelines. In this trial as well, 15 of 50 patients, that's 30%, did not proceed to stem cell transplant due to complications during induction therapy. So, induction therapy should be used with extra caution prior to stem cell transplantation in patients with AL amyloidosis, as complications during induction treatment can make patients ineligible for stem cell transplant, which would be the most definitive treatment. Bone marrow plasmacytosis can affect survival in AL amyloidosis. Bone marrow plasmacytosis of greater than 10% can have poorer prognosis. In a multivariate analysis, bone marrow plasmacytosis of greater than 20% had an independent predictor of overall survival following treatment in AL amyloidosis. We at Boston University looked at role of induction therapy prior to stem cell transplantation based on plasmacytosis in over 550 patients. In this study, bone marrow plasmacytosis was not an independent predictor of overall survival as shown on the left Kaplan-Meier survival curve. Furthermore, role of induction therapy for patients with bone marrow plasmacytosis of greater than 10% also did not have improvement in overall survival. Novel agents have been incorporated after stem cell transplant as either adjuvant therapy or consolidation therapy, with showing deepening of hematologic response following stem cell transplant. And this effort has been led by the group at Memorial Sloan Kettering. Maintenance therapy, on the other hand, has not been studied in clinical trials and is not recommended routinely as standard of care following stem cell transplantation. Of note, ixazomib is currently being studied as a maintenance therapy after stem cell transplantation, and this clinical trial is currently accruing, and the principal investigator is Dr. Heather Landau at Memorial Sloan Kettering Institute. We at Boston University Amyloidosis Center looked at the long-term results of stem cell transplantation over last 20 years in 629 patients with AL amyloidosis. Objectives of this analysis were to address durability of hematologic response following stem cell transplantation and to address long-term survival following stem cell transplantation in AL amyloidosis. Key eligibility criteria were tissue diagnosis of amyloidosis, evidence of a plasma cell dyscrasia, and at least one vital organ involvement, along with minimum measures of performance status, cardiac function, pulmonary function, and hemodynamic stability. Patients were treated on several sequential IRB-approved clinical trials, and age, renal function, time from diagnosis, prior treatment, and conditioning regimen varied among clinical trials. Key exclusion criteria were persistent pleural effusions refractory to medical management, exercise limitation with less than 2 to 3 flights climbed during pulmonary function test, and or oxygen uptake of less than 15 ml per kilogram per minute on cardiopulmonary exercise study, direct hyperbilirubinemia of greater than 2 milligrams per deciliter, and significantly elevated cardiac biomarkers. 629 patients with AL amyloidosis underwent high-dose melphalan and stem cell transplant from 1994 to 2014. The median age was 57 years, and half of the patients had cardiac involvement or greater than 2 organ system involvement. Majority of the patients received full high-dose melphalan at 200 milligrams per meter square, and 44% of the patients received modified high-dose melphalan at 100 to 140 milligrams per meter square. Treatment-related mortality, defined as deaths within 100 days after stem cell transplant, occurred in 7% of the patients. Majority of these patients had significant cardiac involvement. Fortunately, treatment-related mortality in the last 15 years is less than 5% due to better patient selection, as well as availability of other non-stem cell transplant regimens. In addition, there were 11 deaths during stem cell mobilization and collection, and 5 deaths during stem cell infusion, again denoting the medical complexity and frailty of this patient population during this aggressive form of treatment. Hematologic complete response was achieved by 40% of the patients at 6 to 12 months following stem cell transplantation. On an intention to treat analysis, hematologic complete response was achieved by 35% of the patients. 45% of the patients who received full high-dose melphalan at 200 milligrams per meter square achieved a hematologic CR compared to 34% of the patients who received modified high-dose melphalan. Median overall survival for 629 patients following stem cell transplantation was 7.6 years, and 30% of the patients achieved a long-term survival of greater than 20 years. Hematologic relapse, defined as recurrence of plasma cell dyscrasia after achievement of a complete hematologic response, occurred in 32% of the patients at a median of 4.3 years, ranging from 1.5 to 21.5 years. Biochemical relapse, defined as recurrence of monoclonal gammopathy without organ progression or without elevation of involved serum free light chain analysis, occurred in 16% of the patients, and these patients did not require additional therapy at a median of 6.5 years. Organ responses were also evident following stem cell transplantation. Nephrotic syndrome improved in 70% of the patients following hematologic complete response after stem cell transplantation, compared to 30% improvement in proteinuria for those who did not achieve a complete hematologic response. Quality of life, as measured by short form 36, also improved following stem cell transplantation. All SF-36 scores, including mental component summary and physical component summary, reached the age-matched US population norms as shown in the black circles on the graph, reached at 2 years following stem cell transplantation. Hepatic response, defined as greater than 30% reduction in enlarged liver or a 50% decrease of an elevated alkaline phosphatase, occurred in about 60% of the patients at 1 and 2 years following stem cell transplantation. Cardiac responses were also evident following stem cell transplantation. Echocardiographic variables and biomarkers improved following stem cell transplantation. Global longitudinal strain with apical basal ratio as well as cardiac biomarker of BNP improved significantly for those who achieved a complete hematologic response following stem cell transplantation. A large series of experience of stem cell transplantation in AL amyloidosis comes from the registry of CIBMTR, where 1,500 patients were enrolled on this or were analyzed on this study. 5-year overall survival has improved dramatically from 55% to 77% following stem cell transplantation in the last 20 years. Estimated 15-year overall survival of 33% was also reported in a large series from Mayo Clinic investigators. UK National Amyloidosis Center reported on their outcome of 264 patients who underwent stem cell transplantation with a median overall survival of 8.2 years and 33% of the patients achieving a long-term survival at 20 years. Unfortunately, there are no direct comparison of non-stem cell transplant regimens to high-dose melphalan stem cell transplant with respect to hematologic response, overall survival and progression-free survival, organ response, and quality of life measures, except for the French randomized clinical multicenter clinical trial where 100 patients with AL amyloidosis were randomized to receive oral melphalan dexamethasone versus high-dose melphalan stem cell transplant, showing overall survival superiority with oral melphalan dexamethasone. This trial has been criticized for increased treatment-related mortality of about 26% in the stem cell transplant arm. Single-center experience of stem cell transplant and non-stem cell transplant regimens with respect to overall survival was reported by the Mayo Clinic investigators in the last 20 years. We would focus on the time period of 2010 to 2014, and the 2-year overall survival was 94% for the patients who received stem cell transplant and 47% for the patients who received non-stem cell transplant regimens. Similarly, progression-free survival for the time period of 2010 to 2014, 2-year progression-free survival was 73% for those who received stem cell transplantation and was 30% for those who received non-stem cell transplant regimen. Hematologic and organ responses from large publications of stem cell transplantation versus standard therapies with non-stem cell transplant regimens are shown here side by side. Hematologic complete response, renal response, and cardiac responses were deeper and profound following stem cell transplantation, not randomized clinical trials, although. Renal stage, as defined by eGFR, as well as 24-hour urine protein excretion, can predict 2-year risk of dialysis and annual risk thereafter. For the patient that I described had renal stage 2 disease, and the 2-year risk of dialysis is 11 to 25%, as reported by the European investigators, where majority of the patients had received non-stem cell transplant regimen. Her risk at stage 2 disease at 2-year risk of dialysis would be 3% when patients were treated in our center with uniform treatment of stem cell transplantation. Renal response, defined as greater than 30% reduction in proteinuria, can also predict 2- and 5-year risk of dialysis following treatment. As reported by the European investigators, if a patient achieves renal response following treatment, 2-year risk of dialysis is 3 to 10%. Again, majority of the patients in this study were treated with non-stem cell transplant regimens. As reported by our group, renal response following stem cell transplant has a 2-year risk of dialysis of 0%. Longitudinal analysis of quality of life based on short form 36 and AL amyloidosis was performed at my institution in about 200 patients. 41 and 47% of patients achieved clinically meaningful improvement in physical and mental component summaries of SF36 following stem cell transplant regimen. This is in contrast to 23 and 29% of patients achieving clinically meaningful improvement in physical and mental component summary of SF36 following non-stem cell transplant regimens. In conclusion, long-term outcome and results of high-dose melphalan and stem cell transplant in selected patients are unprecedented, with 30% of the patients alive for 20+ years. Moreover, high-dose melphalan and stem cell transplant can lead to durable hematologic complete response with low rate of hematologic relapse, and novel therapies can lead to high hematologic responses. However, durability of these responses is not known off therapy, and follow-up times are quite short. I would like to thank all the members of the basic science and the multidisciplinary clinical team at Boston University Amyloidosis Center who work on the scenes and behind the scenes to make this disease into more manageable and chronic disease. And thank you for your attention. I also would like to inform you guys about this masterclass that is happening on January 10th with all the hands-on workshops with how to do abdominal fat pad aspiration, how to read technetium pyrophosphate scan, how to get prior authorization for some of these newer agents for transthyretin amyloidosis. Thank you for your attention. And now I would like to invite